right, thank you. I guess I'll bring it back full circle and talk about outcomes and technique. So I'd like to thank SAGES for the opportunity to discuss our work today, as well as I'd like to thank SAGES, of course, in addition for the generous grant that they gave to help fund this study. So as we already heard today, that there is quite an amount of technical variation that exists with laparoscopic sleeve gastrectomy, and the recommendations regarding specific techniques have really been conflicting. So there is really no optimal approach that has been standardized, or at least been standardized based on evidence. So our goal was to use surgical videos to identify technique-specific variables that were unique to surgeons who had the best outcomes. So we obtain unedited, de-identified videos of a typical laparoscopic sleeve gastrectomy from surgeons who participate in the Michigan Bariatric Surgery Collaborative, which is a payer-funded, statewide collaborative that's used to promote quality improvement initiatives. And so with that collaborative, we have a bariatric-specific data registry, so we can obtain surgeon-specific outcomes among the surgeons who submitted a video. So we have 30 surgeons who submitted a video during that time frame, and this represents over 7,000 cases of these surgeons. So here's the data that we collected. So from the video itself, we were able to get a whole bevy of technical of things, anything from their energy device, their ports, their stapler vendors, whether they use buttressing, if they oversewed or if they imbricated and where they did that. Things like bougie sizes, which is hard to see on video, we actually got from surgeon surveys, but they were specific to that video. And then, of course, in terms of the outcomes themselves, we categorized them based on safety and efficacy. So we had this question of what is the best outcome? Is it lowest complication, and or is it lowest or most weight loss at 1 year after surgery? So when we looked at safety, we looked at 30-day risk-adjusted surgical complication rates, which is up there. You can see it included leak, hemorrhage, infection, obstruction, and reoperation. That really sort of ties back into the operative technique. And in terms of efficacy, we looked at 1 year patient-reported weight loss. Okay, so we basically ranked the surgeons based on safety and efficacy, and we looked at the top quartile surgeons versus the bottom quartile surgeons, and we analyzed differences in their surgeon characteristics as well as their operative technique. So here's basically all the surgeons ranked based on safety and efficacy. So 1 to 30 on the y-axis based on their patient's weight loss at 1 year, so number 1 had the highest weight loss, and then the rank for safety was on the y-axis. That is their surgical complication rate. So the lowest complication rate was the highest rank. So number 1 was the lowest complication rate. And then across the x-axis is the surgeon's ranks for excess body weight loss. So if their patients had the most weight loss at 1 year, they're ranked number 1. So essentially from this, we're able to categorize surgeons with the best outcomes. So the top quartile were all the surgeons in the red there, and we compared them to the bottom quartile, which were out to the top right of that screen. So this is what their outcomes actually look like. So the top quartile surgeons, their overall mean surgical complication rate was 1.4%, and the bottom quartile surgeons, it was 3%, and that was statistically significant. And in terms of weight loss, the top quartile surgeons had a mean excess body weight loss of their patients of 60%, and the bottom quartile is 54%, and that was statistically significant. So we have these two groups, and we have their outcomes. So we started first with the surgeon analysis. Was there anything different between the two groups of surgeons? And quite honestly, not too much. They're about the same age, number of years in bariatrics. Their fellowship training maybe skewed a little bit higher to the top quartile surgeons, but it wasn't significant. And also surgeon volume. So annual volume and total volume was quite similar between the two groups. The only thing that was statistically significantly different between the two groups was that the top quartile surgeons had slightly faster operative times. Okay, so this is maybe the busiest slide at SAGES, but it basically represents a snapshot of every surgeon's procedure and how they did it. So 1 to 30, all the surgeons, you can see the number of ports, so that top line, so 5 ports, used a nurse practitioner, a PA, or a scrub. They used an ultrasonic dissector. The bougie size are 36. The color-coded tabs there were every single staple cartridge fire. So you can see greens, there's blacks, there's purples, There's TANs that probably don't come up as well. And you can see the number of staple fires that they fired. This is all captured from the video. And everything that's shaded or has a gradient to it means that there's a buttressing on that staple load. And then after that, you can see who oversewed, who imbricated, who did an omentoplasty, who used fibrin sealant, who did a leak test, who did intraoperative endoscopy, who used the drain, and so forth. So this is a nice snapshot of our total patient cohort. So then we analyzed the top and bottom quartiles and wanted to see if there was anything specific or unique to those top quartile surgeons. And quite honestly, when it came down to who was in the operating room or the number of ports that they used or even their bougie size, which is often argued about, there wasn't much difference between the top and bottom quartiles. They used the same median number of staple loads as well. In terms of buttressing, the top quartile surgeons did use a slightly higher, or there's a higher rate of buttressing amongst those surgeons, but it wasn't statistically significant. And again, whether they're oversewing, imbricating, or doing an omentoplasty, you can see sometimes they do it on the proximal staple line, sometimes they do the entire staple line. So there's actually quite an amount of variation. And as you see there with the p-values, there's actually no unique identifying factors or variables amongst the surgeons with the who had the best outcomes, meaning the lowest complication rates and the best weight loss. From our data, we did note that the top-ranked surgeon did have faster mean operative time, so there actually may be other metrics that we can identify from the videos themselves, such as skill, that can correlate to optimal outcomes. But I think another important thing that we observed or that we wanted to point out with this data is even though there is a lot of variation, if that doesn't add any additional value, it may add cost. And so eliminating some of that variation can reduce cost too, which is an important finding. So some limitations, these 30 surgeons only represents 43% of all the surgeons who participate in our collaborative, which is not all of them, of course, but it is still the largest group of videos that are reviewed for sleeve gastrectomy. We asked surgeons to submit basically a typical sleeve gastrectomy, but clearly that can't represent their entire repertoire, and there are some surgeons who had changed their technique over time, so their technique can evolve. So one way to combat that is we just use their outcomes for that 2015 and 2016 timeframe as opposed to the entire timeframe that they've been in practice. Follow-up weight loss, as you can see, was only 52%. This is patient-reported outcomes, so this plagues a lot of other studies that are evaluating long-term outcomes. And I would say for the Michigan Bariatric Surgery Collaborative, our typical weight loss at 1 year is, I'm sorry, what I'm trying to say is that it's not 52%, it's about 70% response rate from our patients. And so this patient population was a little lower than what we were typically used to seeing. And as I said before, this study doesn't take into account surgical skill, which is not how the technique is done, but how well the technique is done. And I think that's going to be the basis of ongoing studies with this data set. So thanks for your attention. I also want to thank our project coordinators, our video collection team, and all the hospitals that participated. Thanks.
Well, I want to thank Dr. Varban and University of Michigan and the Michigan Collaborative for the excellent study and continuing their work in this area. In the interest of time and the live surgery session that's about to follow us, we're going to conclude the session. Excellent, and hopefully you'll be available for questions one-on-one.
Yes, I'll be right
Thank
here.
you.
Thanks.